Welcome to The Explainer. Today, we're cracking open the official story behind a brand new medicine, digging through a huge 178-page report from European regulators to get you the inside scoop.
So how does a drug actually prove it's ready for prime time? Well, we're going to answer that by following the entire journey of one specific drug for a rare disease from the initial idea in the lab all the way to the final verdict. Okay, first things first. Before we can talk about the cure, we have to understand the disease. In this case, it's a chronic autoimmune condition called Generalized Myasthenia Gravis, or you'll see it called gMG.
Imagine your body's own defense system, your immune system, getting confused and turning on itself. That is exactly what happens in MGM. It starts creating these harmful antibodies that sabotage the critical communication lines between your nerves and your muscles. The result? A progressive and often really debilitating muscle weakness. And we're not just talking about feeling a little tired. This can get so severe that it impacts the most basic things you do every day. About 85% of patients get this generalized form, which can affect everything from their vision to their ability to speak, swallow, and even breathe. Now, this is considered a rare disease, affecting only about 15 to 25 people out of every 100,000. And because of that, finding new, effective treatments is a huge challenge. This creates a really significant unmet medical need for safer and better long-term options for the people who live with this every single day.
All right, so that's the problem. And that brings us to the potential solution that was put in front of the European Medicines Agency, a new drug called Nipocalimab.
So what's the deal with this drug? Well, it's a type of medicine called a monoclonal antibody. You can think of it as a tiny, lab-designed, guided missile. And instead of just managing the symptoms, this missile is designed to fly right past them and target the root cause of the problem by hitting a very specific part of the immune system.
This is where it gets really clever. So you've got the problem, right? These harmful antibodies. Now, normally, your body would clear them out. But there's this protector, a receptor called FcRn, that basically keeps saving them. It's like a recycling center that keeps putting the bad guys back into circulation. Nipocalimab is the blocker. It comes in and just shuts that recycling center down. And with the protector gone, the body can finally get rid of the harmful antibodies, which should reduce the attack on the muscles. But of course, a cool-sounding mechanism is one thing. You've got to prove it actually works in a real-world, super rigorous clinical trial. So this brings us to the main event. This was a 24-week study with 199 participants from all over the world. And the key thing here is that it was randomized and double-blind. That's the gold standard. It means neither the patients nor their doctors knew who was getting the real drug and who was getting a placebo. That's how you get unbiased results.
So, how do you measure if it's working? Well, the ultimate question was simple. Did the drug actually improve a patient's daily life? To figure that out, they used something called the MG-ADL score, which is just a way of measuring how the disease impacts everyday things like talking, walking, or breathing. A lower score means you're doing better.
And here are the results. Just look at the difference here. The folks who got Nipocalimab saw their daily activity score improve by almost 3.5 points. That is more than double the improvement seen in the placebo group. This wasn't just a statistical blip. The regulators looked at this and agreed it was a genuinely meaningful improvement in people's lives.
Okay, so the drug works. Case closed, right? Well, not so fast. A positive result is only half the story. Now comes the really critical part, weighing those benefits against any potential risks. So, in the benefits column, the evidence was pretty compelling. It worked. It showed a clear, fast, and lasting improvement for patients with the two most common types of antibodies that cause gMG.
But, and there's almost always a but in drug development, you have to look at the other side of the scale. And there were some red flags. The drugs seem to mess with cholesterol levels and another protein that's linked to heart health. This is the classic dilemma with any drug for a chronic disease. How do you balance a clear benefit today with a potential risk someone might face if they take this for decades?
And this is the absolute heart of the matter, isn't it? Regulators were staring at a classic standoff. Clear short-term benefits that could dramatically improve someone's life versus some pretty significant unknowns about the long term. So, after months of going back and forth, the EMA's main committee, the CHMP, finally reached a decision. And this wasn't a quick decision. You can see here it was a pretty thorough year-long process. There were multiple rounds of questions, reviews, more questions, but finally, in September of 2025, they issued a positive opinion, which was finalized a couple of months later. But here's the kicker. It wasn't a simple yes. This was not a blanket approval. The regulators put a really important restriction on it. The company wanted the drug approved for patients with a third type of antibody, but the EMA said no. Why? Because the trial only included 3 patients with that antibody type, and the regulators basically said, nope, that is not nearly enough data for us to feel good about the risks and benefits for that group.
And so, this is what it all boils down to. This is the final, official verdict. It is an approval, yes, but it's a very cautious one. It narrows the approval down to only those patients where the evidence was crystal clear, and it comes with big warnings for doctors to keep a close eye on cholesterol and be aware of those long-term risks.
You know, what this whole case shows so clearly is that getting a new drug approved is never a simple yes or no. It's this incredible tightrope walk between hope and caution, and it really forces us all to ask that tough question. When it comes to diseases people have to live with for the rest of their lives, how do we balance the benefits they can feel today against the potential risks of tomorrow?